Okay guys, so this is just going to be a short special topic on urinary access, urinary diversion. So this is sort of what we're talking about here. We've got a kidney, hopefully that's got a dilated system in it. Stick it under ultrasound if you can, and put a wire into it, and then move over to fluoro and exchange with put a catheter in there, and then usually something like this happens. So why do you do percutaneous nephrostomy? So there's basically three indications, okay? Relief of urinary obstruction, urinary diversion, and an access for a therapeutic procedure or diagnostic procedure. So when I say relief of urinary obstruction, what I'm talking about is stones and cancer. So typically, this kind of stuff is, you can use it for rapid decompression of an obstructed collecting system, especially when, retrograde drainage isn't possible. So if you've got somebody with urosepsis or acute renal failure, remember there's different kinds of renal failure, and, obstruction is, post-renal failure is, or, pre, intra, and post. Like the post is like that is a cause of renal failure. And, in most cases, just giving them a Foley will fix it. But if the obstruction is higher up, then you have to end up doing this. So you can reduce mortality in the setting of urosepsis, from 40% down to 8%, depending on what you read. So those are ideas for acute or urinary obstruction, relieving that. Urinary diversion. So these are situations where let's say there's been a urine leak from an iatrogenic complication. It was GYN cuts the ureter, doing some kind of GYN thing. If you've had pelvic cancer or radiation or something like that that's caused a fistula, or you've got refractory hemorrhagic cystitis. Remember the step one buzzword for that, cyclophosphamide. Remember that that's a chemotherapeutic agent that can cause hemorrhagic cystitis. And then for diagnostic and therapeutic procedures, the rare one, although may not be rare on multiple choice, is this entity called the Whitaker test. And so this is a situation where you've got a UPJ obstruction, like a kid with a UPJ obstruction, like congenital, or not, and you're trying to differentiate between, okay, this person looks like they've got hydro. Is this a functional hydro, or is it a mechanical obstruction? And the way you can tell the difference is you put a pressure monitor in the bladder and you put a pressure monitor in the urinary pelvis, and you compare the pressures. It's typically done prior to pyeloplasty for UPJ obstruction, but I mean it's like super duper old school. Most places have probably, a lot of IR people haven't done them. But it is a thing, and because it's a thing that dinosaurs would be familiar with, it may be a thing that dinosaurs would like to write a question about. So just that's what it is. It's probably all you need to know about it. All right. Other things, this is much more common, is access for stone removal or dilation of a stricture or stenting that can't be accomplished from a retrograde approach. All right, so contraindications, these are always things that are very testable, so this is very high yield slide right here. Severe coagulopathy, so what the hell does that mean? Okay, when I say that, this is what I mean. This is, you read different numbers, different places. Institutional stuff varies from place to place. So, please don't send me an email that says, my institution, we say an INR has to be less than 1.4. These are the numbers that I would memorize. I think that if they give you something on the test, it's going to be, a scenario where a guy has a platelets of 5 or something, or his INR is super duper high, and it's not going to be Your choices are 1.3, 1.4, 1.5, 1.6. That would be utter bullshit. I guess I could still do it, but this is the general numbers that I would remember. So INR less than 1.5, platelets greater than 50, severe hyperkalemia, like potassium levels greater than 7. Obviously, you don't want to do a procedure on anybody like that because they're a ticking time bomb. So if you had a situation like that, you would want the next step would be to dialyze this patient before you're doing a procedure on them, so they don't have a huge MI while you're checking their blood pressure. And speaking of blood pressures, typically people say less than 180 systolic is safe. Otherwise, you need to correct that prior to starting a procedure. If it's an outpatient procedure, you want to hold antiplatelet agents or anticoagulants for like 5 days when possible. And of course, this is another absolute contraindication that you'll read about. Technically not possible, so you're not allowed to cross the colon, spleen, or liver when you're sticking the kidney. So if there's no way to avoid that, then you can't do the procedure. All right, so what does a procedure look like? So typically, the patient is placed prone. Most places will angle the ipsilateral kidney like 20 to 30 degrees. Most places will tell you to target about 10 centimeters lateral to midline, but not beyond the posterior axillary line. And the reason you do that is if the tube is too medial, you'll cross the paraspinal musculature, which A, makes dilation really difficult, and B, hurts like a motherfucker. So you don't want to try to dilate through the paraspinal musculature. That you won't get a good customer service review after that. And then if you're too lateral, you could end up perfing the colon. So that's usually right around where people will tell you to go. The next thing, and I change the color of the kidney to make the vessels easier to see, is you want to pick an entry site that's around 30 to 45 degrees. You want to hit a peripheral posterior calyx. And the reason that you do these things is this idea of this bloodless line. Notice how the vessels here are sort of on one side and then on the other, and then right through here is this quote-unquote avascular line. It's not truly avascular, but it's less bloody than it would be if you went through here. And there's a name for that. It says Brodell's line. So that's where you want to go. And like I said, peripheral and posterior possible. And then if you have to take an intercostal approach, obviously you want to avoid going inferior to the margin of the rib to decrease the risk of an intercostal artery injury, that neurovascular bundle. And if you have the choice, it's much better to go T11, T12 relative to T10, T11 for avoiding lung and liver and spleen, those kinds of things. So lower is better. Avoid the inferior margin of the rib if you have to take an intercostal approach. Okay, so some more technical aspects. So there's two basic approaches or ways that you have to approach this thing. Either you've got a dilated system, which is ideal, or you have a non-dilated system, which is much more difficult. So for a dilated system, most people will teach you to do what they call a single stick method, which is basically what I cartooned out. You stick them once, you stick them where you're supposed to stick them, you put the wire in, you dilate up, you put the tube in. A double stick is often necessary when you're dealing with a non-dilated system. So what is a double stick? Double stick means you stick them anywhere you can stick them, basically, to opacify the collecting system, which allows you then to get a more accurate target for your second stick, which is going to be your real stick. And you can use contrast or you can use air. So when opacified, the posterior calyxes are typically seen end on, and the anterior calyxes will project more laterally, and then AP projection. However, if you're injecting a small amount of air, CO2, you expect that the more posterior calyxes are going to fill, because it's the bubble is going to rise in a prone patient. So depending on what you stick is where you're going to see things. But you basically create a dilated system with a double stick method. Your first stick is to do the dilating, either with air or with fluid / contrast, and then everything is the same after that. So nephroureteral stents are sort of the ideal endpoint for somebody that's requiring more permanent placement of a nephrostomy tube. Why, might you say? Well, I should back up, and I should say, there are external nephroureteral stents, which is basically a situation where you've got a blockage like here, and then you place your nephrostomy tube with a stent all the way down into the bladder, and then you got a bag hanging outside of the patient, and that sucks. Terrible quality of life. You got a bag of piss strapped to your back, and the tube is super uncomfortable and painful, jiggling around out there, laying on it, that kind of stuff. So the ideal scenario is to internalize the stent so you start out here, and then you convert it to double J. So it's way better, but it requires cystoscopic retrograde exchange. Like, if you can't do that, then you can't do a double J. You're not supposed to place them. So contraindications for either type would basically be anything that is obstructing outflow down here. So if your bladder doesn't work, it's neurogenic or irritable, incontinence issues, bladder tumors, or you've got an outlet obstruction. If you're draining the urine to here, but then there's still no way for it to get out, then you didn't do any favors. So then in that situation, you'd say, well, what do I do then? Well, then you just have the tube right here, right? So if you were given a scenario and it was like, which of the following patients would you do a nephrostomy tube versus a nephroureteral stent? And it was, a guy who has a permanent stricture here. Well, then you would want to give him a nephroureteral stent. Even better would be a double J stent if that was an option, because his blockage is here, and you've got a tube here like that. So then he's being able to drain urine from here to there, getting past that blockage, doesn't have a tube hanging outside of him, everything's cool. All right. If they gave you a scenario and they said, guy has blockage here, he's had radiation fibrosis here, but he's also bad diabetic and he's got a neurogenic bladder and his bladder doesn't work for shit, it won't empty, and he has high residuals, etc., etc. Well, then he just gets a nephrostomy tube. He doesn't get a nephroureteral stent because he can't drain out of his bladder. And then I guess a third scenario, and this is something we'll talk about later, would be if he's got really severe prostate cancer or BPH or something, and the obstruction is here, but this is normal. He doesn't have fibrosis. He doesn't have a stricture. Kidney works fine. Ureter works fine. The problem is here. Well, then he gets a percutaneous cystostomy tube. He gets a bladder tube. So that would be like how you would solve those clinical situations. So just, if you have to think about it, if you're an IR guy, it's going to be super easy. You shouldn't even be listening to me. But if you're a non-IR person, then diagram this out. Draw yourself a bladder, a ureter, and a urethra, and say, where is the blockage at? And then common sense it to where you have to put the drainage at if you were given a scenario on which one of these you were going to have to pick. All right, moving on. I'll rehash this again at the end. So, size selection. So, how do you decide what size stent you're going to put in somebody? Well, believe it or not, the easiest way to do it is just height-based. Height of the patient is actually a very reliable method to decide the length of the ureter. You can use a wire to measure. Like you could put a wire down there and like do measurements and stuff based on that, but oftentimes, believe it or not, it tends to overestimate the length. So if given a choice, height-based, and there's charts. They're not going to say this person's 6 foot tall, how many centimeter stent you're going to put. They would have to show you. I would think if they were going to ask you a question, it would just be like based on the height of the patient. All right, so I talked about these nephroureteral stents, and then I talked about these double J internal stents, so this thing, the double J, and I said that, you have to be able to do a retrograde exchange thing. Well, something else that you want to do before you just deploy this thing and leave it is place what they call a safety. So, like that. So basically, you've already made a hole, you've already made a track to be able to place this thing, and so typically, you will leave an extra tube that's like a nephrostomy tube, which is basically what the safety is, in place for like 24 to 48 hours, and you cap it. So you cap it. It's not draining out. You're assuming that it's draining inside. You bring them back in like 24 hours and you look. If their system is like blown up, like they haven't drained any urine for 48 hours out of this kidney, well then you know this thing's not working. And then you have to uncap it and let the urine run back on your shoe. But if you image, you drip a little bit of contrast in there and it's not dilated, well then you know this double J stent is working, and then you can remove the safety and then they're good to go. So basically it is just to make sure that the internal double J ureteral stent will work, and you just give them 24 to 48 hours to drain some urine, and if it's draining the urine then you're good to go, and if you're not then you got to leave it in. Alright, so a couple of special situations. One is the encrusted percutaneous nephrostomy tube. This is actually fairly common if you have to deal with these things. It's an annoying part of placing them, is then you have to manage them. So an encrusted tube is extremely difficult to remove, and in fact it may be impossible to exchange over a guide wire as a result. So some strategies for dealing with this. Some people will say you can put a hydrophilic wire along the track, along the side of the tube to maintain the access, and then you pull the tube out and then you can use that wire. Just remember that if you can't get the pigtail, this is another thing just to know, if you can't get the pigtail to release, and you can't pull the thing out with the pigtail still in place, you'll lacerate the fuck out of the kidney. So the pigtail has to be released. Or what if you can't get it to release? You can sometimes advance a peel-away sheath over the tube to straighten the pigtail, and then you can safely remove it. So if you had a situation where you've got this piece of shit tube that's encrusted and it won't unpigtail, that you've cut the whatever and it won't release the pigtail, you can place the sheath over it, and that should straighten it, and then allows you to pull the whole thing out. Alright, tube fell out. Another very common situation that you deal with these tubes. So if it's within the first week, you're going to need a new track. Your track's no good. If it's been more than that, if you've got a quote mature track, hopefully they won't tell you that it's been 8 days. They'll say that this guy's had an indwelling tube for years or something, and then boom, I'm dealing with a mature track. You can usually reaccess those without any kind of a problem. You can just inject gentle injection of contrast into the exit site, and that will allow you to delineate that there's a mature track. And then you can, catheter and wire down through that thing, put a wire down in there, and then you've got access, and then use that. So you don't need a new track if it's mature. If it's within the first week, you'll have to stick them again. Alright, so you may have seen the ureters occluded. So, like by IR, like actual occluder devices stuck down in there, and you may say to yourself, why are they doing that? So urinary occlusion may be necessary in addition to urinary diversion and patients who have urinary leaks or fistulas or urinary incontinence or intractable hemorrhagic cystitis. So there's a whole bunch of different methods for doing this. Antigrade placement of coils, gel foam, tissue adhesive, detachable balloons. A lot of places you will see people talk about placing larger coils at the proximal and distal ends of the nest to help avoid migration of the smaller coils. Also, you can't get away most of the time, they tell you not to, of occluding just the proximal ureter. You'd be like, well, that's where the urine's coming from. I'll just occlude the proximal part. You're supposed to occlude the distal ureter as well because there's like risks of, ureteroiliac artery fistulas and infection, these blind loop syndrome kind of things going on. So you're supposed to take the whole thing down if you're going to do it. All right, what about transplant? So there's just a few things that are different. So remember, transplants are anterior, they're not posterior, so you're going to have an anterior approach. You're also, this is important, you're going to have a very lateral approach. You want to go as lateral as possible because you're trying to avoid the peritoneum. And typically most places will tell you to do a middle to upper pole target. So lateral, anterior lateral, middle to upper pole. All right, so we're going to switch gears slightly and talk about sticking tubes in the bladder. So if you're going to access the bladder, your target is going to be 2 to 3 centimeters above the pubic symphysis, or if that's not a choice, the middle and lower third. Like if you cut the bladder in thirds, like upper third, middle third, bottom third, the junction of the middle and lower third here is where you're gonna hit. So middle and lower third junction, or 2 to 3 centimeters above the pubic symphysis. Anterior bladder wall, it's an anterior approach. Avoid the trigone of the bladder because that causes bladder spasming over and over and over again when you put a tube in there. Typically you want to hit midline, and the reason you want to go midline is there are these things called the inferior epigastric arteries, right? So you want to avoid those, and the safest way to do that is a midline approach. Most of the time people will tell you to put a bladder catheter in, a Foley catheter first, but you don't want the bladder to drain. You want it to be distended if possible when you're sticking it. It just makes it easier to stick. A lot of times if you've got an adequately distended bladder, you can do the entire procedure under ultrasound via like a trocar technique. And if you can't, sometimes you can do a combination of ultrasound and fluoro, just like you do for a nephrostomy tube with like a modified Sellinger technique, wire in, thing out, dilate the track and then place the tube. So just a summary here, midline, avoid the epigastrics, 2 to 3 centimeters above the pubic symphysis, or lower to mid 1/3 junction. Placement of a Foley catheter that is at least 16 French is typically what you're going to need for long-term drainage to avoid it from getting clogged and those kinds of things over and over and over again. Indications, so this is a testable slide here. So indications, acute bladder retention, when you can't just put a Foley catheter in. It can be from BPH, prostate cancer, neurogenic bladder, etc. It may also be beneficial for people who've had urethral trauma, radiation-induced cystitis, a bladder to colon fistula, a bladder to vagina fistula, or just horrific urinary incontinence that for some reason a Foley catheter won't work for. Relative contraindications, they've had a bunch of pelvic surgeries before, they're a big fat person and it's impossible to get at their bladder. Coagulopathy or inability to distend the bladder or displace overlying small bowel. Okay, so real quick, I just want to review a couple of scenarios here. This is a way that this can be potentially tested, is to say, all right, you've got a patient with problem X. Which urinary diversion technique are you going to use? And so let's sort of run through a couple different scenarios here. So what I've done is I've outlined, I got a kidney, I got a ureter, I got a bladder, I got a urethra, and the red box means that's where the problem is. So problem can be fibrosis, problem could be stones, problem could be bladder tumors, problem could be BPH, or it could be prostate cancer, or it could be urethra, got, Lorena Bobbitt cut my penis off. It could be whatever. You got an issue here. All right, so let's go through the first scenario. So normal bladder, normal distal ureter, normal urethra, but he's got fibrosis or stricture or stones or something here. So the ideal scenario would be to give him a double J ureteral stent. You could, depending on the way the question would be written, say that you would leave a safety in for 24 to 48 hours to make sure that this is working correctly. Some newer literature is suggesting maybe you don't even need that, but when I trained, everybody pretty much did that. So, and then, once it's working, then you can pull it out. But his ideal scenario would be to internalize that form to get past that obstruction. All right, next situation is you've got a problem in the ureter, but also the bladder doesn't empty correctly for whatever reason. There's something wrong with the bladder. So if you were to give him a double J stent, you would just be draining into a bladder that doesn't work. And then you would have urinary retention issues, and you'd end up getting all kinds of problems there too. So it doesn't make sense to drain urine into a bladder that doesn't function. So in this situation, he just needs a nephrostomy tube because he has to decompress here. Now, long-term situation, maybe he needs an ileoconduit or something, and then you could put one of these from here down into his ileoconduit, and that would be better for him so he doesn't have a tube hanging out of his back. But in the meantime, he's going to end up with one of these. All right, last situation is a guy with an outflow problem. So he's got BPH, he's got maybe a neurogenic bladder, he's got big prostate cancer here, he's had a urethral injury here. So this is a guy that would be a good candidate for a cystostomy tube. This works fine, this works fine, this works fine, just can't get out of the bladder, so we'll drain out that way. All right, there you go. That's the high points on urinary stuff for IR.